My name is Shane. I run the events over at TEN Capital Network, and we have a great event for you today about lung cancer and genomic testing, which I am not super familiar with myself, so I'm excited to hear it today. And then we have an amazing company afterward pitching in the space, so stick around for that, of course. We have Dr. Patel here, who's going to give his presentation, and then if you have any questions, you can go ahead and drop those in the chat box, which I'm going to open up for everybody now. You can put those in there throughout the session and we'll get to them when we can. And with that, I'm going to pass it over to Dr. Patel to get things going.
Thank you, Shane. Hi, everyone. I'm Sandip Patel. I'm a professor in medical oncology here at the University of California, San Diego. Nice to be seeing everyone, and thanks for the opportunity to speak about this topic. Lung cancer, as folks are aware, is the most common cancer type, the most common lethal cancer type, not only in the US, but worldwide. It represents a disproportionate burden of disease. And while historically, and still, smoking-related lung cancer is the most common form of lung cancer, folks who've never smoked before can get lung cancer. In fact, if you just took the proportion of lung cancer that occurs in people who've never smoked, that's more patients than with chronic myelogenous leukemia, chronic lymphocytic leukemia, acute lymphoblastic leukemia. So even some of the more common types of cancer that you may have heard of, even if cigarettes never existed, we'd still be unfortunately dealing with this problem. And more importantly, the innovations in lung cancer detection have led to the first time ever 2 consecutive years in improvement in overall cancer survival in the US. In other words, because lung cancer is so common and because it's so lethal, our innovations in improving lung cancer have driven an overall decrease in mortality relative to prior years in cancer for the first time ever. And so one of the ways we've accomplished this is through early detection. This has worked in breast cancer, it's worked in colon cancer. We haven't quite gotten there in lung cancer yet, but given its disproportionate burden, not only in the US, but worldwide, I was tasked with discussing some of these challenges and also the genomics revolution. Probably the most common cancer type for which next generation sequencing is utilized is lung cancer, because we have over a half dozen actionable targets, basically anywhere in the world. And in the US, we're close to a double-digit number of genetic targets for which we have targeted therapies for. And so I'll be talking both about early lung cancer diagnostics and detection, as well as genomic testing more broadly, the advantages, disadvantages, challenges. And then we're going to hear from the Voxy team about they have a unique technological approach to overcome one of the major challenges we have in detection, early detection, as well as one of the potential opportunities for folks on treatment. And so this just describes the effect of chemotherapy across stage. So you see go left to right, stage 1, stage 2, stage 3. And the blue plus the red, which there's luckily less deaths from chemotherapy due to our improvements in supportive care. But you see here for stage 3 lung cancer, almost 2/3 of patients in some series are dying. So stage 3 breast cancer does not have this morbid prognosis. Stage 3 colon cancer does not. So lung cancer, it's much more on the pancreatic cancer side of the spectrum in terms of how severe it is, or glioblastoma multiforme, for example. So historically, some folks in yellow would do well without chemotherapy. But the key aspect here is if we can detect cancer at earlier stage, we improve survival. That's the bar in blue. We want to have that be as small as possible because that's death regardless of if they got any treatment or not. And you can see even for stage 1 in 3 patients are dying of cancer at 5 years, which is a major problem. And so we want to do better. And to do this, we need to shift the stage of diagnosis from advanced stage, stage 3, to stage 1. So early detection is key. And so one of the first studies that looked at this was the NLST study. It is a randomized controlled trial looking at low-dose CT scan versus chest X-ray. And here you see the eligibility criteria, age 55 to 74, current and ex-smoker within 15 years. And this is a large study, 53,000 patients at 33 centers, median follow-up at 6 years and ongoing. What we see here is the relative reduction for lung cancer death is 20%. which is quite substantial. Now, when you look at that's the relative number. When you look at the absolute number, you say, well, 3 fewer deaths per 1,000 screened. That doesn't sound like a lot. But if you look at the numbers for breast cancer or colon cancer, it's almost half of that even. And we don't think about that. And so when you look at the total number of folks who are at risk, this is a huge number. In fact, lung cancer screening and cervical cancer screening numerically have the biggest relative benefit. And from an absolute benefit standpoint, because lungs are in both men and women, you can envision the math works out that lung and colon cancer screening have a big overall effect. And so this was not just a one-off study, that was a US-based study. This is the Dutch-Belgian lung cancer screening studies this year. It's a randomized controlled study, which is the highest level of evidence. And sorry, for some reason, my slides are advancing one. I'll have to figure that out later. And you see here that in stage 1 disease, we have a 59% detection with low-dose CT versus no screening. And so that's a huge impact on early detection. I showed you earlier why that's so important to save lives. We want to find these patients early, cure them, so they can go on living their lives. And you see here very similar criteria to NLST. This, in fact, is the criteria that's now approved by Medicare with a couple caveats for approval in the US for utilization. This is what the VA uses quite successfully for screening. Now, the enrollment here at 15,000, predominantly male, mainly due to smoking history. Women tend to smoke less than men. And at 10 years, we had a reduction of 24% in lung cancer mortality and 33% in women, though wide confidence intervals because it's a smaller group. What this means is this impact of lung screening is actually a bigger impact on these women than even mammography is, and even cervical cancer screening. So this is hugely impactful if we can do it right. And one of the issues that we have is our tools for looking at the lungs, which are low-dose CT screening, are somewhat crude. They can show a spot, but they cannot tell you what that spot is. And risk stratifying those spots is very difficult. It leads to a lot of anxiety for patients, anxiety. And to understand what's going on, you have to get repeat scans, which have a radiation risk, which some patients are not keen on, or to do a biopsy, which can have risk for bleeding, infection, or pneumothorax, which is a lung dropping. And so the US Preventive Task Force have updated their criteria, but you see here the lung cancer mortality reduction and is anywhere from 10 to 13%. This is a similar population, age 50 to 80, 20-pack-year smoking history, and screening should be discontinued once a person has not smoked for 15 years or develops a health problem that would lead to additional issues. So you see, we're trying to increase the number of patients who have access to screening. But you see here a couple things that are of interest. One, the percent overdiagnosis is about 6%. Overdiagnosis can mean many things. It's people have to get additional scan. It's folks who may have to get that biopsy, which may have that risk. And also making sure that the folks who most are at risk don't get left behind. But the life years gained per 100,000, when you see here, you're almost at 7,000 life years gained per 100,000. That's actually a very large number in the screening world. And it actually makes many other screening modalities look less effective, even though they're accepted. And we should be doing all of these. This isn't a mutually exclusive zero-sum game. We can and we should be doing all of these, but maybe there are tools that can help us do this more effectively. And so shared decision-making is key. There are many risks when we do low-dose CT. There's an anxiety risk of getting the scan. There's complication risks from the diagnostic procedures, and there's radiation risk. Serial imaging can add independent cancer risk, and studies suggest that for every 108 cancers detected, we could cause one cancer by radiation-induced cancer, right? So a modality that doesn't involve radiation may help us. In aggregate, are we saving more lives? Absolutely. But is it potentially at the cost due to radiation exposure of the loss of one of those lives you otherwise be saving? And unfortunately, yes. And so this is a graphical schema of what those numbers look like. CT technology has improved, so we are delivering less radiation, but these risks are still real and something we have to keep about. Is there a non-invasive way that we can better stratify risk and maybe use in conjunction with CT imaging to help patients maximize their benefit and minimize their risk? And so there are guidelines, society recommendations for management of these indeterminate pulmonary nodules. I can tell you in my own clinic, this happens all the time. We're constantly dealing with nodules. We do not know what they are. And we're often following up with CT scans. But I just told you that because of the radiation risk, there's a non-zero risk that we actually cause harm. And so is there a way non-invasively that without radiation, we can help folks fight their cancer without their potential cancer, without giving that risk of radiation exposure? And you see here, for a low-risk single nodule, for example, if there's an 8 mm lesion, we're getting a CT at 3 months. A PET CT is several-fold more radiation than a CAT scan, right? And so there is a radiation risk with a imaging-only based modality. Now, is this the best modality that we have? Is it the gold standard? Yes. But is there a slight risk to this major benefit? Yes. And so if we can drop that risk threshold with the non-invasive technology that can help us risk stratify, this would really be a game changer for us. CT time is limited. If you go outside the US, it can take months to get a CT in many health systems, even in the Western world, that are less resourced. And so are there ways that we can kind of slick the freeway, so to speak, in a good way, so folks don't have to wait either for their scans, or they don't get radiation exposure while they're trying to do that? And so one of the technologies that's really helped us is genomic testing. And this can be done as tissue biopsy, can be done as a liquid biopsy. And what is molecular residual disease? And so MRD is a key genomic-based factor. It's typically either done with bespoke assays where you sequence the tumor, find these passenger mutations, and have a personalized biomarker. This is used in colon cancer, the Signatera test, or off-the-shelf assays, which sometimes have less sensitivity because they're looking at driver mutations only. And there's a sensitivity gap there that we have to overcome. And so what we see here is this MRD diagnostic threshold. And what we're trying to do is detect cancer underneath this threshold, because otherwise we can detect it clinically with CAT scans with radiation-based means, or we're waiting for symptoms, which is the blue bar, which we don't want to have, right? And so the earlier we can detect, I showed you earlier, the closer we get to stage 1, the better off we are. And so genomic technologies are there, but their sensitivity is lacking and there's an expense. And so for many parts of the world, this is difficult to achieve, and also difficult to do over multiple time points due to the expense. Cell-free DNA is DNA that's shed by the cancer. It's in a tube of blood, but we're often looking for 1 or 2 fragments of DNA in blood. And so the chances of finding that right space, right time, you have to do a phlebotomy. That's an invasive procedure. Can we find a non-invasive, non-radiation-based way of thinking about how we can detect cancer earlier? And so when we talk about clinical applications for cell-free DNA, there's also dynamic monitoring. So up to now in this talk, I've talked about early detection, which is key for cure. But for patients who are on treatment, or patients who receive treatment who are monitoring for relapse, are there other ways we can stratify their risk to either intensify therapy, de-intensify therapy, look for cancer without that radiation exposure? And so cell-free DNA is one, but it's a relatively expensive technology that requires monitoring in the blood. So you have to do a phlebotomy, which many patients, often they live far away. Many health systems don't have access to this. And so are there other ways that can help us detect the cancer early? So if there's an early relapse, we can potentially intervene, because there is a curative intent window even at relapse. And so to summarize, lung cancer screening, highly effective preventing cancer-related death, the most common type of cancer. And there actually are screening strategies in never smoking patients. There's actually a huge problem in Asia. And so there's studies out of Taiwan, China, Japan that are looking at screening a never smoking population, which I actually think one day we'll be doing stateside. But that's a story I'm happy to discuss more, but we're not as far along in that science. And so I can't speak as definitively to that. Currently, this relies on low dose, but still radiation exposure CT screening of the chest in patients of the right age with the right smoking history and the current ex-smoker status within 15 years. Though, as I said, I think for Asia very much, there's going to be a never smoking paradigm. And I think we're going to actually one day probably have that in the US, though we're probably several years away for that. However, this involves radiation exposure. It involves anxiety around tracking around lung nodules, which has medical, financial, and social costs. So a non-invasive, non-radiation-based way of assessing these lesions for risk would be hugely impactful. Liquid biopsy can help in assisting in triaging nodule cancer risk, but that's a blood draw. And so patients' rural access, many health systems don't have access to the genomic type tests that are required, and these can be quite expensive. And so newer non-invasive technologies for screening and nodule stratification, in my opinion, are needed to intercept cancer at the early rates to increase cure rates. And that's when I heard about the technology Voxy is developing, which you're going to hear more about, which is why we're partnered for clinical research to see how we can best utilize this technology to help patients before they become patients. Help them while they're still in screening, help augment screening modalities, and help augment early detection and dynamic monitoring without radiation-based methods or even blood-based methods. And so with that, this is my contact info. We have a couple questions in this chat, which I'll start with, and then happy to take any questions that may come up. What is the least invasive test for lung cancer? That's a great question. The least invasive test for a patient is going to be a low-dose CT scan relative to a blood draw phlebotomy, which is minimally invasive. However, that has a non-zero radiation risk, which as you add up, can actually have a negative impact and cause cancer. I think the stat we mentioned earlier is 1 out of 108 scans that are detected. So we're losing one there. What about dogs? And there's a link, and I'll click on that link later so I don't knock myself out of the slides in case anyone has a question. My speculation would be that imaging-based technology, blood-based technology, and potentially the Voxy technology that I'll let them discuss should be able to help detect cancer. Oh, sorry, the question more specifically is dogs can smell to detect cancers. Actually, that's a great point. And so dogs are likely smelling some of the aromatic compounds that are being uniquely produced by cancer. This is actually a known phenomenon. In fact, there's a study of nurses who can smell certain infections and cancer because they have a certain odor that they can detect over time. And I wouldn't be surprised if this is a subset of the volatile compounds that are generated by the cancer that you're going to hear from the Voxy team that they can actually detect in a more quantitative way. But for bladder cancer, lung cancer, and here colon, prostate cancer, the ability for our canine friends to help us has been described, and I do think it's related to the production of these volatile compounds that they can detect that the human nose can generally not as well. Man's best friend or human's best friend, I agree. Great questions. I'm happy to take any other questions that may arise, or if there are any in the chat or the Q&A or just verbally.
Yeah, thank you so much, Dr. Patel. If anybody does have any more questions, Dr. Patel will be sticking around so he can answer more questions at the end. Feel free to drop those in the chat box. We will also follow up with everybody. If you have any further questions offline, we can answer those too. But if nobody has any other questions at this time, I'm happy to bring up Greg from Voxy, and he can give his pitch. Awesome. Yeah, and if anybody in the audience has any questions about Voxy as they're presenting as well, feel free to drop those questions in the chat box too. Greg, you can go ahead and start.
All right, thank you so much. Greg Sherwood, I'm Chief Technology Officer here at Voxy, and the rest of the team is around the table to help answer questions when we get there, but it's a pleasure to present, and thank you, Dr. Patel, for getting us going here. All right, just as an overview, the Voxy is have a vision of saving lives one life at a time. Our mission is to create an approachable breath diagnostic. So we're raising a safe of $5 million, about 90% filled. Use the proceeds for commercialization of our patented breath technology. We're 4 times better, 10 times smaller, and lower cost, and might provide some of the solutions for what Dr. Patel was hinting at. And we do have an update too, that there's an angel tax credit approved at the state of Minnesota. You receive 25% of your investment back, I think after a year after your investment. So that's still approved, I believe. So this is the global challenge. Cancer is increasing across the world. There's many, and the market is increasing for diagnostics. As Dr. Patel was showing us, the early detection is very effective at providing cures for these people. So the earlier we can get there, the better. So there's going to be a lot of investment into early detection diagnostics. It's not advancing here. Yeah. So 84% of lung cancers are late to diagnose. We have 130,000 deaths in the US, globally almost 2 million. Oh, here we go. Okay. Oops. Oh. So an overview of our technology is that we have a test that can look for chemical patterns. We have a novel sensing technology that converts that chemical energy and the chemical information into electronic information and provides a breath print. And we can take that breath print, put it into a categorization type of software, and it has a high impact for being able to detect these diseases very easily and very early. So as was brought up by the dogs, it's the VOCs that we're sensing with this technology. It's the volatile organic compounds that get produced by cancers. And this has been known for a long time. There's lots of literature based on VOCs expressed in the breath. And what's also been found is that the VOC signature is different for each type of cancer. So this graphic shows that there's multiple types of diseases that produce VOCs that are unique to that disease state. So that's the target of what we're after here. So this is research that was put out a few years ago. And it's an example of lung cancer VOCs. So what you see is essentially an expression of the green VOCs, which are what healthy people express in their breath. The red is the change that occurs because lung cancer is present. So not only do we have unique VOCs get produced by the cancer, but there's also the VOCs that are normally there get changed in concentration. So the result is that we get a change in a pattern that we're looking at from the array of sensors that we produce. So this is an overview of what that array is made up of. This is our clinical device. It's a desktop unit, and we use this circuit board that has 40 chips on it, makes up 120 sensors for these VOCs. And we are currently miniaturizing that. So the commercial version will be a handheld version that contains all of the electronics that are in this desktop, but it's been miniaturized, and we're looking to commercialize that. The magic or secret sauce behind this is the graphene sensor that you see there. It's just a few hundred microns square. It's got a layer of graphene, which is a single carbon layer, atomic layer of carbon. And then we put specialized monolayer coatings on each sensor to make it sensitive to specific types of VOCs. So what we see is that we get a full spectrum of VOCs that we sense in this breath. We do it real time. It's accessible, it's accurate, and it's approachable, as it's only 1 minute of breathing. So it's very non-invasive. This is an example of a cross-reactive array that we use. It has sensors that can be tuned to different families of VOCs, and you can see a list of those on the left side of that. But the output is what's shown here is a heat map, or it's a variation in pattern based on the types of chemistries that are there. And what you see here on the top are subsets of lung cancer. So essentially 4 different types of lung cancer. And you can see that small cell is very different than the other ones. So, and we've had some lab data that tells us that we can see the difference between small cell and non-small cell lung cancer. So this is the care pathway, and it's an example or graphic of where we might be able to fit in. Do you have cancer at all, or are the nodules that you have cancerous? So there's a whole care pathway that we could enter the market in. What we think the best place is are the nodules that we see cancerous, and this addresses the need that Dr. Patel was approaching, and that there's a lot of stress involved with that, and a lot of radiation potentially that can happen. Just trying to figure that out, and so we think this is the best place to start our approach. We already have a lot of human data based on this. We've tested almost 200 people with cancer versus no cancer, and are producing these patterns of comparison. So you can see that the controls are that blue circle inside, and the shapes around that in that radar plot show the difference in VOC concentrations based on people that have biopsy proven cancer. And we take that data and put it in the LDA plot. We see that we can separate these populations pretty significantly just based on that VOC data and the patterns that we're getting. And so this is our go-to-market approach. We have a lot of suppliers that we're dealing with now, as well as healthcare providers that are providing a focus for us. We have clinical partners that we're developing at the University of Minnesota, UC San Diego, and Iona, which is in South America. And then we have are approaching these integrated healthcare systems that are both the provider and the payer. And this is where a good benefit will be, because the cost of there's potential huge cost savings with reduced CTs and better outcomes. Currently, we're in phase 2 of this design and implement. We'll be moving into phase 3 for verification, approaching the FDA for clinical trials and early approval for potentially breakthrough. And then we have commercial readiness and launch in 2026. This is an overview of just some estimated COGS we have at this point. As we get into this design of the handheld, we can use both a mask or even a mouthpiece if we wanted to. It's a small device, and we believe that we can drop our costs significantly as we get into higher volumes. And working with our suppliers, we think there's a good potential for all of this. So, yeah, we have core IP for this. This is a relatively new area of technology as far as graphene and the use of this non-invasive technology. So we've been able to populate the patent landscape pretty heavily with protective patents. We have 26 granted and over 30 filed, so 30 additional ones that are filed. So we believe we have pretty good coverage throughout this care pathway that we're going to be using this technology in. And so there's competition that we have. There's liquid biopsy, which has some challenges with accuracy. It's also not quite as accessible. There's other breath companies that are out there that are still in development and not really commercialized yet. But we think we can have a very high accuracy cancer detection system that's very accessible. And with 1 minute of breathing, we can provide results back in a matter of 2 or 3 minutes after that breath test. So we believe we have a lot of the details, and we can provide information back quickly that address a lot of the needs that Dr. Patel had mentioned. And then the financial summary, we're in investment now, we're development. And once we get into commercialization, we feel like revenues will be reflected as they are in this table. So here's our team. Ping was not able to join us today. He's a cancer survivor, very passionate about this technology. And then the rest of the team here is with us. We're all very experienced in medical devices. We have decades of FDA approvals and device development, so we have a very strong support for this team. And then the deals we have, Ping has the detailed here, raising $5 million on a safe for 90% build, 20% discount on post-money, $20 million of post-money. And again, we have this 25% rebate from the university or from the state of Minnesota. And so the proceeds are used to develop our commercial device, get us through validation and verification and FDA approval. So excellent opportunities. We have a number of companies that we could combine or to partner with strategically that may have a long-term market interest in this technology. So with that, I can leave the summary here and open to any questions that might come up from the audience.
Yeah, we'll start with these couple in the chat box, and then Dr. Patel, I'll go to you next. So Andrew wants to know why only 15 years of coverage.
Only 15 years. I'm not sure I understand the question.
It might have been pertaining to a specific slide that you had.
I did the patent coverage. Oh, because I guess because we filed these a few years ago, there's only 17 years available for a patent coverage. So we've eaten into that window a little bit. But as we add more patents in, we'll have patent coverage up through probably 2040 right now.
Okay, great. And then tax rebate is only to Minnesota residents, ?
No, it's for anybody, any investor from anywhere in the world.
Okay, great. If anybody else has any questions in the audience, feel free to drop those in the chat box. Dr. Patel, did you have any questions you wanted to ask?
No, I think it's a great presentation. I've of course seen a lot of this data, which is why our institution is collaborating, because we're very keen on trying to figure out ways of facilitating screening, really not only in lung cancer, but actually multiple cancer types, to the point that that's been made. And so there are lots of use cases we're collaborating on, not only for early detection, but also dynamic monitoring in a non-invasive way. I guess the only question I'd ask, mainly just for the purposes of the audience, kind of getting a sense of what we've been discussing, is for the Voxy team, is there a sense on when this is being developed? This is currently still something that is at 2 sites, but as this goes to mass production, as this is something that one day may be utilized in a primary care kind of point of care office, or something that's sent to patients directly, and kind of the data comes back centrally, what's the vision around how that decentralization process looks like? And I guess, what are the opportunities, not only to, as we talk about the medical home and bringing care to the home, but what are some of the opportunities to partner with insurance companies and folks who care a lot about care at the point of delivery at home, as opposed to in a health system?
Sure. So I'll start with that question. I answer, and if there's anybody else on the team here that wants to jump in, but we are developing the system so that the data is transferred to the cloud via phone that we supply. So it can be used anywhere. That data will be centralized and processed and returned to the prescribing physician within a few minutes. We perceive that this technology that we developed does not have to be redesigned for any other disease state. So the same array of sensors can be used for multiple cancers or infectious diseases, so that it's very extensible from the original design that we have right here. So we're willing to partner with health companies or healthcare companies or other researchers that are doing other disease states, that we could supply the hardware and data back for them. So that's all available.
Awesome. Again, yeah, if anybody else has any questions in the audience, feel free to drop those in the chat. I'm also going to run a poll right quick for everybody in the audience. Please just indicate your best interest, and we'll follow up with you as necessary. Dr. Patel, did you have any other comments, feedback, or questions for Voxy?
No, I think it's been a very interesting collaboration, and I'm looking forward to seeing the results. But rarely do we get an opportunity to work on something that may have a really broad impact, not only for patients, but also folks who could be patients. And so the opportunity to help folks is what I'm excited about.
I guess I could just add too that the comments on the dogs. So the dogs have a capability of sniffing in the part per trillion level. The gases that we are sensing are actually in the part per billion level, and it's the advantage of graphene and the sensors that we've built, that we can do that in a full humidity environment. So if you look at any kind of competitive technology, that they're taking a breath sample, they have to bag it, remove the moisture, and run it through their system. Where this is really unique, because we can convert that chemical information into electronic information in real time. And there's nothing to collect or ship or do that in that perspective. So I think it's a really gigantic step forward.
Great. Yeah, if anybody else has any more questions, again, feel free to put those in the chat box last minute. Answer the poll as necessary. And I think with that, we'll go ahead and close it out here. I want to thank everybody for joining us. Dr. Patel, Greg, the Voxy team at large there. Our audience especially, thank you for joining us. We'll be sending out the recording tomorrow and more information. Yeah, I think that'll do it for today. Thanks again, and we'll see you at the next one.
Awesome.
Thanks, every day.
Bye, guys.